Assalamu alaikum. Good morning, everybody. Thanks for the introduction. I want to thank the SSBMT and the organizer committee for invitation to talk about CAR T-cell in multiple myeloma. So, as we know, from locomotion study, actually, so they look, actually, it's real world study, look at the patient, actually, they are refractory or relapse on multiple myeloma therapy. And what the outcome for these types of patients. So here, as you can see, this one seems not working. So actually, the overall response rate around 28%, and these like the different lines of therapy. And so here you can see the median progression-free survival was around 4.6 months, and the median overall survival around almost 1 year. So what the solution for that? So what's next? You have patients that are refractory or relapse, and what's the next step for them? It's CAR T-cell. So before talking about the CAR T-cell, just we'll talk about some structure about the plasma cells. So plasma cell, actually, there are several antigen-presented plasma cells. So as you can see, there is CD138, K light chain, CD19. But the most thing that I will be interested in was B-cell maturation antigen, BCMA. Why that? Because you can see it's expressed in the B cells, but you can see it's over or heavily expressed in the malignant plasma cells, as you can see at the end. So it's overexpressed and heavily expressed in the malignant plasma cells. It can express also in the normal cells, actually. So here it's the same. So you can see that's expressed in other cells, but you can see how the number of copies of plasma or B-cell maturation antigen in the plasmacytoma can express also in the lymph node and blood lymphocyte. And this, like BCMA, it's important in the cell growth and survival. So what are the two current approved CAR T-cell in multiple myeloma? So currently, actually have two products that are approved in multiple myeloma. So the first one, which is the ID-cell, it's approved in 2021. The second is Celta-cell, it's approved in 2022. So ID-cell, actually, it's like second generation CAR T-cell, anti-BCMA, murine, it's FV with 4-1BB costimulatory domain. The Celta-cell, second generation CAR T-cell, also it's targeted BCMA, but it's two BCMA. So what are the studies that leads to approval of this product? So start with the first one, which is the KARMA study, which lead to approval of ID-cell, actually. So you can see here they included the patient, they have like refractory to 3 or more lines of therapy, and they did the process of the leukapheresis, then bridging therapy, then reinfused the products again. So actually here you can see the primary endpoint with the overall response rate. So if you look at so here actually they give different doses. So you can see there is the 150, the 300, and 450. So if you look at overall response rate around 73%, this is actually good because we're talking about patients who are refractory to 3 lines of therapy. So overall response rate around 73%. And if you look based on the dose, actually, the overall response rate 82% if the patient received 450 dose, compared 50% if received the 150 dose. And if you look at about the duration response, you can see here, as I mentioned, so this is the blue line, it represents actually the dose of 450. It's better compared the patient received the green light, which is the green lines, which is green dots, which is the 150. Duration of response, according to best response, if the patient achieve after the infusion CR or CRI, actually, or stringent CR, they do better compared the patient still having like PR disease. And also, if you look at the overall survival, the same. The patient received the full dose, they do better compare if they receive the 150 dose. Here, if you look at subgroup analysis, actually most of the patients actually favor the CAR T-cell, the ID-cell, except if the patient, as I mentioned earlier, received the smaller dose, which is the 150, will not favor the CAR T-cell. What about the second product? So second product, which is the Celta-cell. The same, so the study is called CARTITUDE-1, actually. So also included patients who is actually they're refractory to 3 or more lines of therapy, including PI, IMID, and anti-CD33 antibodies. But here, actually, in Celta-cell, it's not like ID-cell. Celta-cell, actually, it's like fixed, you give the dose based on the weight, actually. So the dose given based on the weight. So you can see the overall response rate around in 97 patients, it's around 97%, and around 80% achieve stringent CR. And if this is the updated, actually, so if you look at the time, like so the progression-free survival around almost 35 months, overall survival actually is not reached. So, and you look actually, if you look at this, also the study, actually CARTITUDE. So if you see the patient, they achieve actually CR or the MRD negativity, actually they do very much better compared to they achieve that response. So what about, so this is what we're talking about patient in clinical trial. So in real life, so we know this, some patients are not eligible to the to be eligible for this clinical trial. So what are the data about the therapy outside the clinical trial? So to answer that, actually we have like this actually real world study. So they look actually one actually for the ID cell, the second celta cell. Still, so these patients actually were excluded from the clinical trial where they are not eligible for many reasons, either organ failure, there was previous therapy, anti-BCMA. Regardless of the cause, even though they underwent CAR T-cell, you can see here, like, the progression-free survival actually around almost like 7 months, with the median follow-up 5 months. So these like patients that refractory to multiple line of therapy and they're not fit for the clinical trial. The same also for the celta cell. You can see these types of patients also the median follow-up around 5 months, and with the 6-month progression-free survival around 79%. So still, if the patient are not fit clinical trial, still they can real-world data show that they showed benefit from the CAR T-cell. So CAR T-cell approved like after failure of after the patient received 3rd or 4th line of therapy. So can you move CAR T-cell earlier? So to answer that, actually there is 2 studies. One, the KarMMa-2, phase 2 study actually for ID cell. They included patient early relapse within 18 months after autologous stem cell transplant. And there is the CARTITUDE-2 cohort study, actually evaluated celta cell after 1 to 3 period lines of therapy. So what is the result? So this is the KarMMa. And the result for that, you can see the ID cell given a second-line therapy showed overall response rate around 83%, CR rate around 45%, and MRD achieved negativity around 85% of the patient. Median progression-free survival almost 11 months. What about the CARTITUDE-2? The same, showed almost the same response, so overall around 95% of our response rate, CR 90%, 75% with 12 months progression-free survival, median not yet reached. So what else? So actually this is like the phase 3 trial, the KarMMa-3 and CARTITUDE. So I'll talk about first the KarMMa-3, so phase 3 trial, actually, and the patient received 2 or 4 prior line of therapy. So this is eligibility. So actually this patient actually, they receive 2 or 4 lines of therapy. They receive either the standard of therapy, randomized, either receive standard of therapy or the CAR T-cell. Then they will look about the primary endpoint, which is progression-free survival. So actually here you can see with median follow-up 18 months, so the ID cell actually median progression-free survival 13 months compared to standard regimen, which is 4 months. So here we have phase 3 trial about the CAR T-cell, which you can use after if the patient failed multiple lines of therapy. Not only that, you can see the outcome also. If the patient achieves MRD negativity, the outcome will be better. So you can see here, so the MRD negativity achieved, so the median progression-free survival will be around 17 months compared to the one who didn't achieve MRD negativity. This is at 6 months follow-up. At 1 year, you can see if the patient achieves MRD negativity, they do better with around 14 months progression-free survival. So actually, so the most important thing, so usually we treat the patient either by CAR T-cell or autologous transplant, and the patient achieves, let's say, CR or a very good partial remission, but what about the quality of life, which is important for the patient? So the patient, his disease is his disease like with excellent response, but what about the quality of life? So here actually it showed that with the patient who achieved actually CAR T-cell, actually the quality of life is good and favor that compare if the patient receives standard of therapy. So this is very important slide. So this reflects about the outcome of the patient multiple myeloma if they have high risk feature. So you can see here the progression-free survival differ, it depends. So let's say, so here actually the overall survival around progression-free survival 13 months, but if the patient has high risk cytogenetic feature, so they do actually better with the CAR T cell compared to the, sorry, this one not working. So second graph actually has high risk cytogenetic feature. The ID cell group, they do better compared to the standard regimen. Also, if the patient has RISS stage 3, they do better with the CAR T cell. If the patient has high tumor burden, actually they do better with ID cell. If the patient has extramedullary disease, you can see the progression-free survival almost 7 months, which is difficult to control sometimes. If the patient having like triple classes refractory disease, so actually with the CAR T cell, this will be better. What about the CARTITUDE, which is about cell to cell? This is almost also phase 3 clinical trial. So you can see with the median follow-up 15 months, actually the progression-free survival is better with the CAR T cell group, the cell to cell, compared to the standard regimen of therapy. And this is also showed us here about the progression-free survival and comparing with the, depend how many lines of therapy the patient receives. So let's say, actually the cell-to-cell group, they better compared to standard of care, but if the patient receives only 1 line of therapy, they do better compared to the patient receives 2 or 3 lines of therapy, the same with the the standard of care. So this is the future. Actually, the future now, they include the plan to move CAR T cell earlier. So this actually to CARTITUDE 5 and 6. So CARTITUDE 5, actually they say the patient who is not eligible for transplant, then will be randomized either to see if like the standard of care, and in addition to the CAR T cell. And they will look for the result. Or even if the patient is eligible for autologous stem cell transplants, so the patient will be randomized either to receive the autologous stem cell transplant or the CAR T cell. So we'll wait the result of these 2 clinical trials. So we'll talk about the efficacy about this CAR T cell now. So what about the safety profile? So actually CAR T cell has several toxicity. One of them is cytokine release syndrome, ICANS, cytopenia, and hypogammaglobulinemia. So it's important also to look for that. So CRS, so what actually is triggered by activation of T cells, lead to release of the cytokines within, especially interleukin 6. So it leads to the patient start to have symptoms, fever, hypotension, and hypoxia. So, and there is a grade 1, 2, 3, 4. And based on grade, usually we treat the patients. So what about, so this is actually just to show us about the incidence of CRS comparing 2 products, the ID cell compared to cell to cell. So you can see the CRS grade 1 or more, it happened around like 84% in the ID cell group compared 90, which is more in the cell to cell group. And not only that, so that's just to show you the median onset of CRS. So in ID cell, actually it's 1 day. So if they give the product, so within 1 day, the patient can develop CRS. But for cell to cell, take about 7 days. And median duration of the days actually around 5 in the ID cell group compared to the cell to cell. What about neurotoxicity? So neurotoxicity actually grade 1 or more in ID cell, around 18% compared to 20%, almost 21% in cell group. So here actually showed us the infection. So actually the percentage of infection grade 3 or more, almost comparable in both groups. COVID actually is not, wasn't mentioned in that study actually. So what about cytopenia? It's one of the complications either due to lymphodepletion, but you can see here the median onset of the time until count recovery around 2 months in the ID cell group, and 60 to 70% of the cell-to-cell group actually recovered by day 30. By that, I conclude my presentation.